Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, my name is Molly Casey, and I'm on the marketing team of Axxess. I would like to thank you for joining us today for a conversation where we will hear what it's like to lead from the front lines of the coronavirus COVID-19 pandemic. Joining us today are three leaders from EvergreenHealth Home Care. Brent Korte is the Chief Home Care Officer, Sarah McGuire is the Director of Clinical Services, and Molly McDonald is the Quality Program Manager for EvergreenHealth Home Care. EvergreenHealth Home Care is one of the largest home health and hospice providers in the Pacific Northwest, averaging 250,000 visits a year. With more than 600 employees, EvergreenHealth Home Care is a not-for-profit agency associated with a local hospital facility, which was one of the first known cases of COVID-19 in the United States. And joining the Evergreen Home Care team is John Olajide. John is the founder and Chief Executive Officer for Axxess, a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Before we begin, a couple of quick housekeeping items. Your phones have been muted, but you may submit questions through the chat functionality. We will follow up with you after the webinar to respond to your questions. Additionally, we will provide a link to everyone who attended or registered for the webinar today with a recording after the event. Now, I'd like to pass it over to John to share our conversation today.
Okay, thank you, Molly, for that kind introduction. Thank you, Brent and Sarah and Molly, for taking time to be with us today. We're very grateful, and we look forward to hearing from you and sharing your thoughts with everyone that's dialed in today. You dealt with a situation that's totally unprecedented, and very few people ever have to experience. So I'm sure everyone on this webinar is eager to hear about what that was like. From our conversations, Brent, at Home Care 100, I have an appreciation for Evergreen Health being one of the largest home health and hospice providers in the Pacific Northwest. But let's set the stage, Brent, by having you tell us a little bit about Evergreen Health and your background in healthcare.
Thanks, John. Hi, everybody. It's an honor to join the Axxess team for this call. Our goal today is to try to share with you some of the lessons we learned in the last 7 weeks, in particular that first month, in order to help everyone who's listening perhaps be more prepared for when and if this does hit you. And I imagine many of you are currently in the moment now. And for those of you that are, we're reaching out from here, trying to give you the rah-rah and the pat on the back. We know it's a tough time. Again, my name is Brent Korte. I'm the Chief Home Care Officer at Evergreen Health. We are a hospital-based home health and hospice with an inpatient hospice as well. We're in an interesting position because we have a large census. In particular, before COVID started, we had a larger census than we do now. Perhaps 2,000 patients between home health and hospice, with the majority on the home health side, around 1,400 on the home health side, and the remaining in hospice and then the inpatient. But we're also part of a medium to small sized hospital system in an area where there are very large hospital systems. I imagine everywhere in the United States now has large hospital systems, but we have an independent, I'll say small hospital system just outside of Seattle, Washington, in Kirkland, Washington. One thing that we do hope to portray today is that, in spite of the fact that we are a larger provider, we all have experience working with standalone, public, branch-based, big and small, different home health, home cares, and hospices. So we want to make sure that we're not speaking strictly from the perspective of a larger provider, because we've we've worked in different setups and different sizes, and I can tell you that one thing that's been so helpful for us here is having this level of support. And for those of you that are running smaller businesses or providing care with a smaller census, the act of supporting your folks and doing all the things you already do is an enormous challenge, and we hope to provide some advice today to help you along that.
Excellent. Thanks, Brent. Sarah, why don't you share briefly what your experience in healthcare has been?
So this is Sarah McGuire. I am a nurse by trade, and I've been with Evergreen Home Care since May of 2011. I'm coming up on my 9-year anniversary here. Started in the field, had some med-surg experience prior to coming to home care, and went from working in the field and kind of seeing the operations in the field, and then came into the office as charge nurse and then manager before stepping into the director role. So getting to see from start to finish, referrals to visits, discharges, all the way through into the management.
Excellent. Thanks, Sarah. Molly, please share what your experience has been in healthcare.
Sure. So my name's Molly McDonald, and I'm actually a physical therapist by trade. And I've been at Evergreen about the same time, actually the same exact time. Sarah and I started on the same day, almost 9 years ago. And I started right out of PT school as a traveling physical therapist, so I was able to really see kind of different settings and decide where I wanted to land, and home health is where I really wanted to be. So I started in the field here at Evergreen, and had a similar path to Sarah. Came out of the field and did some different roles in the office, and eventually, probably like 6 or 7 years ago, landed in quality and regulatory, and I've been there ever since.
Thank you, Brent. Thank you, Sarah. Thank you, Molly, for that introduction and just letting us know your background in healthcare. So we have been hearing about the coronavirus in Asia in January. Did you imagine that it could find its way to Kirkland? And what were you doing to prepare? Brent, that question is for you.
Sure. This is a great question, John. And the first time we've been asked this, the answer is absolutely not. We did not imagine that it would come here first. I think that we didn't have much time to think about that once we realized that it happened, the idea that one could think that possibly it would hit the West Coast first because we do have a lot of direct flights in and out of China from Seattle. One could also think that it could have come to California first, but it could be that many of us, it could be human nature that we don't really react to things until we see them happening. We'll talk about this a bit later, but we've done a lot of work here to prepare for earthquakes, and myself included. It's been hard for us to take a drill completely seriously because it seems like such a foreign concept until it actually happens. But we definitely have been indoctrinated with the idea that there's well, of course, this thing is very real. And we've certainly never experienced anything like this. There's 12,000 home healths in the United States, just under 12,000, and about 4,000 hospices and 6,000 hospitals. And if you do the reverse math on that, it's very, very unlikely that it would have happened to have come to a skilled nursing facility just 2 miles to the east of our offices. But it did, and hopefully we've navigated this in a way that has helped save lives and most importantly, kept our clinicians safe.
Wow. So Sarah and Molly, what were you seeing and how were you preparing for this?
So when I believe it was the first case in the U.S. Occurred in one of the counties that we serve, about 15 miles north at Providence facility. And once that happened, a couple weeks later, we've had a travel screen in place, part of the regulatory changes after that the large Ebola outbreak. And so we have revised that one over time, and we revised it again with this new virus that came through. Didn't have a name at that time, just coronavirus. And we instituted a symptom screening process for every visit on January 28th. As you know, about 10 days after the first case was identified in the United States. So it wasn't necessarily focused on travel, it was symptoms. And the clinicians were instructed to do that symptom screen before every visit, before they got there. And so that was the first thing that we did.
Okay.
And also with infection control, you know, we've had a nurse educator, you know, we had one for many years, and now we have two on home health and hospice who are a point for infection control. And they've been really leading our infection control education and training for many years, kind of ongoing. And that really has set us up well for situations like this. It's really helpful. It's kept infection control front and center. It's always on our minds during a crisis like this or ongoing. And it's really helped us not only meet regulations, but to continue to practice best practice and be as safe as we can be when it comes to infection control.
Excellent. So you're doing all this work, then comes the end of February, and your facility is the first positive test result for the coronavirus in the United States. Brent, this is for you. What were you thinking when the results came in positive, and how did you respond? Did you have a crisis response team in place? What protocols and procedures did you put in place? What was going through your mind? What were you doing?
Yeah, great question. February 28th in the evening, I got a phone call from my boss, who's the COO at the system over post-acute care, and she asked me if I was sitting down, and I wasn't sitting down. I was actually laying down with putting my daughter and my son to bed, and I was, you know, kind of telling them to shush, post reading books, etc. And I got a call and had to step out, and I was told that we had the first death at our hospital in the United States. And I can tell you, I remember John very specifically thinking immediately about the consequence of that. I thought more specifically about the hospital because almost all of our team happens to live in the community that our hospital specifically serves. So not only do we work for our community hospital, but our community hospital supports our families. We've received care. We've had kids here. This is it's a beacon of our community. So we're very worried about that, and about people that work in the hospital. It was a very long night leading up to a very long weekend. Our incident command center was propped up at a system level over the weekend. One could picture, you picture something in a TV show where people are kind of running around and there's papers flying, et cetera. It wasn't like that, but I can tell you that there were a lot of people trying to figure out a lot of questions, and in any one given set of 10 minutes, you had to be prepared to answer probably 20 different questions and make decisions on the fly that maybe would have taken approvals and even days and weeks to answer beforehand, just to keep our staff safe and to figure out what to do. So it's definitely a moving target. Like Sarah said earlier, there wasn't much known about the coronavirus. If I'm correct, the term COVID-19 wasn't, at least it certainly wasn't ubiquitously used, and I don't know that it was even diagnosed yet as a name of a disease. And I know Sarah and Molly are going to speak a bit about protocols, but know that none of us, not EvergreenHealth, nor most of the providers in the U.S., I imagine that most of the folks on this call were prepared for this. There's no protocol for an on-the-ground epidemic hitting our community first. So we definitely weren't prepared in that way. It was interesting before I pass off to Molly and Sarah. John, the CDC was here very quickly, and that was an interesting it was great to have the CDC here, and it also allowed EvergreenHealth as an organization to help work with the CDC to define protocols nationally. So it was not uncommon that someone from the CDC would walk into our incident command, ask how we were doing something, and then they would go out and update their website nationally. So that was very interesting to see that happening.
Wow. So Sarah and Molly, how were you responding at this time?
You know, like Brent said, it was surreal, and we were all kind of responding minute to minute, like quite literally minute to minute. And we all came together, and there were some long nights and things like that. And you know, as Brent spoke to the unlikelihood that we thought it was going to be here, our past drills and emergency planning and protocols were really focused around, you know, winter weather events and, you know, our inability to get to patients because of severe weather. And so we were really doing some very fast shifting, but, you know, a lot of the outline was there. You know, we immediately started talking about PPE, and we immediately started talking about the safety of our clinicians and the safety of our patients. But in the beginning, none of us knew really how long-term this was going to be. So it was a very minute-to-minute, day-by-day, night-by-night situation for us.
Yeah, there was quite a bit that we did in the beginning. We assessed what we had on hand, what we thought we might need. We looked through all of our patients that had come out of the Life Care Center recently and started kind of doing our own little mini contact tracing with our clinicians. And then once we had that, we had to ask, well, now what? You know, and ask for guidance from the hospital incident command. And then from that beginning on, it was putting things in place as quickly as we could, but doing it as reasonably as we could. We didn't want to put a resource out to clinicians that we knew they would save and keep without making sure it was as accurate as possible. So just kind of wanting to make sure that our version control, if we knew something was going to be updated, being really thoughtful before putting it out there, was definitely something that we thought a lot about. And then just how we communicated and how frequently we communicated and what we included.
Yeah, I think it's worth mentioning. I'm gonna mention, pick on something that Sarah said, that specifically version control. That goes to speak to the fact that in any provider, small or large, that we put a lot of thought in our industry and in healthcare in general into what a protocol is. And maybe it takes literally months for us to figure that out. And the idea of version control, when you're trying to issue a protocol in 1 hour that will be used within that hour, is very relative. And the idea of very quick decision making and quick progress was really the name of the game, and one reason we were able to be so successful.
You know, Brent, it's interesting that you're talking about version control, but considering how unprecedented this was, I'm sure you needed to look for credible sources of information to help you get through this. So what sources of information were you going to?
So John, we relied heavily on the National Association for Home Care and Hospice, or NAC. Certainly the CDC, because they were on site, and then our local Department of Health. Early on, we leaned on public health and epidemiology and avoided the news spin. We had to avoid the news spin because the news were literally out front. We physically had to avoid the news vans, but on top of that, we learned early that being on the ground and seeing what was really happening versus what was being portrayed in the media was not exactly accurate. So what we've said from day one is, if there's a public health official or a physician with a white coat on, listen to them. If it's there's a lot of both news and political spin out there, and as providers and as first responders and as folks at the front lines, we have found it critical to get down to the distilled science of everything. So, this comes down to the idea that the importance of leaning on public health and supporting public health spending. Washington State didn't choose to be the first to be the initial front line of this, but we did as a state choose to invest a lot in public health. And in some way, I think when I said this early on, my team probably didn't really like hearing it from me, but it may be a positive and a blessing that Washington State was the front line, because we were pretty darn prepared. We have a community that is very involved in the Seattle area, very scientific, very technology based, and people went straight to the science of it, and we took that approach. We've had a lot of questions from our clinicians around, well, hey, I heard this, or this has happened, et cetera. I heard something on the news. And every single town hall we've had, I think we've had probably 15 of them between both home health and hospice. We continue to remind everyone that a virus is studied scientifically, and the solution will be had scientifically, and our approach will be engineered through a scientific approach. That goes from everything to the correct type of visit we should be providing to PPE.
Okay, talking about PPE, Brent, we've heard about all the challenges with PPE. So what was your situation with PPE when first dealing with patients who tested positive?
So I imagine PPE is on everyone's mind. So hopefully you'll be able to glean some advice from this. All we knew again of the virus was initially from what we all had seen on news reports prior to February 28th, and then a little bit of local communication from public health folks. So we essentially didn't, the amount of PPE we had was we were probably overstocked for a what would be a normal week. We were always well prepared. We have a strong infection control program, which Molly had mentioned earlier, and we would have been otherwise ready to go. But have to prepare for 600, well, about 450 patient-facing staff members to be properly protected for that visit number that was thrown out earlier, about 250,000 visits a year. We're talking about probably roughly Washington State's entire post-acute PPE utilization just for us, and it's a maddening number. And the challenges were twofold. Number one, our partner for PPE is on allocation, which I understand many, if not all, supply providers are on allocation. So for those of you that don't know what that means, it means that we are given, essentially, we're allowed to order the amount that precedent has set in the past. So if we ordered 195 masks per month for the last year, then we get 1,200 for the next year. And that clearly doesn't work. So that's been very frustrating, and we've been reaching out to other partners to try to fill our needs. And in doing so, we've seen some very interesting things. So I want to throw out an air of caution that we probably all have heard at this point, that there are a number of unscrupulous players out there that are selling masks which don't exist, or taking money beforehand and promising that they're going to send masks. And then there's some significant inflation of the price of some PPE, and we've noticed that. We've been very fortunate to be able to avoid that. And here's the main reason why. We, from day one, were reminded by our infectious disease doctor, Dr. Francis Rito, that conservation is as important as procurement. So we have been aggressively conserving PPE from day one, and that is a very unpopular notion. When I think in particular in the United States, I would say more so in the U.S. than in other countries, we have this concept that sparkly and bigger is better, but In fact, I'll pick on Texas for a second, and with tongue in cheek that, Texas is definitely a bigger is better sort of state, and absolute respect to Texas. I've spent a lot of time down there, and, it's certainly an American mentality that the more we have, the better we're going to do. But in this case, the more you have, the more overprotected you are, the more risk you're in. So, for instance, if you were to don an N95 mask in a situation where it's absolutely not needed, what happens 2 months later when there will be situations when it absolutely is needed and you've used them all up? And we've had to have that very forward conversation with our clinicians. And I would say that probably half of them got it right away. Half of them thought we were probably using too much PPE. A fourth of them thought that we're using too much PPE, and then the other fourth were feeling less protected than they wanted to be. So conservation, aggressive conservation, and what that means is ensuring that the masks you use and the gloves that you use are used in according to your local public health guidance.
Got it. So, Brent, I heard you say that too much PPE is just as dangerous as too little PPE. Is that what you're referring to here?
I would say so, yes.
Okay, excellent. So, Sarah and Molly, do you have anything to add to that?
I think the only thing that I would add is that Brent mentioned about half of them got it, and about the other half were varying shades of not quite there yet. Managing the staff and the anxiety that comes with that group that weren't quite there when it came to what our recommendations and what we were providing for PPE was challenging. Because you were constantly reassessing what you were doing and kept getting questions. It was challenging to manage, and it took up a lot of emotional energy and time.
And I think really keeping your management team on the same page, because it's a lot of saying the same thing. And like Brent and Sarah mentioned, we have to stick to the science. And so we felt like we were repeating ourselves, but each manager needed to be able to say it to their team. And every time a new article came out or every time a new anything, you'd get a link and they'd say, well, what about this? What about this scenario? And we had to continue to go back and say, based on the science, based on what we've been seeing in our own hospital, based on the experts that are on site. It was really a lot of talking people through, even though we know they knew it, we just had to continue to talk through it. Everything felt so new all the time.
Yeah.
Wow. So while all of this was going on, how did your team respond? Were people anxious? Were they afraid? Brent, how was your team dealing with this overall?
Yeah, there was a ton of anxiety, and I would say there still is some now. The way that we've been able to respond has largely lent towards allowing folks that are possibly too anxious to essentially not work if they don't feel comfortable. Now there's a fine line there, because had this continued, our peak day was April 5th. Had this continued and our peak day would have been, let's say April 25th, then we would have needed absolutely every employee that we have. So as our census has decreased, it has allowed us to allow folks who want or sometimes, John, feel the duty to work. There have been both sides of the bell curve, right? Some people are quite anxious, and then other people feel that they need to be on the front lines because it's their duty and their calling. And those, all of our folks, we're not judging, right? We're not judging anyone in this time. This is certainly a very tough time, but I can tell you that I couldn't be more honored to work with those folks who are just ready to get out there in front of people and help them right now.
Wow. So Sarah and Molly, so how did your team respond? What were you saying? Were they anxious? Were they afraid? Is there anything you want to add to that?
I just think, really what we've seen is the anxiety and the fears. It's really the most constant and the most variable thing we've seen at the same time. It's always there, but the different levels are going up and down all the time. People are okay, and then they come back around because new information came out. So it just really, it's constant and variable.
Well, that is interesting. Most constant and most variable, and you have to juggle all that at the same time. Amazing. So, Brent, communication is so important during a crisis situation. I'm sure you know that, and you're leading through that. So, Brent, talk a little bit about how you talk to your team at a time like this, how often you were talking to them, and what type of information were you sharing with your team?
Yeah, good question. We have been focusing on multiple ways to communicate with people who digest information in multiple ways. The one thing we haven't been able to do is obviously in-person communication. So we started a weekly town hall meeting, and the weekly town hall meeting was house-wide. So the first one or two were with all of our employees. So we had upwards of 500 folks join. We had to be quite careful about that, because if you had, as you know, John, if you had an unmuted line with that many people who had joined, it'd be quite difficult to manage everyone asking questions, and obviously a lot of anxiety at the time. This was week one, so this was before there were infections even outside of Washington State, I think. So, and we also started daily emails. So one of our excellent managers has been overseeing communication on a daily basis, sending out protocols, sending out the why behind the protocol, and a lot of reinforcement. I think we have very consistently been having to reinforce our PPE protocols, and that could be for a couple of reasons. One, it's complex, and two, maybe our clinicians aren't hearing exactly what they may want to hear. We can't protect them with masks we don't have, and I think a lot of leaders are going to be faced with this. One of our excellent colleagues in Maine, Ken Albert, he's the CEO of Androscoggin Home Health and Hospice, recently had to make a decision to either send his staff out into the field with no mask or with inadequate protection, or essentially have them not do visits, and he chose to protect his staff and not send them out, and I think that was the right move. He since then has worked hard from a legislative perspective to ensure that he had folks. But anyways, back to communication. We all know that if we had 100 people on our staff, we have 100 different ways that people like to receive information, and it's our duty as leaders to make sure that we reach out and share information in a way which is certainly tangible for each of them. We also want one other thing to mention. We have actually got more than one other thing to mention, John. A lot of one-on-one communication. So we have been very ubiquitously available to our staff who have unique needs, all the way throughout our leadership ranks. So if someone has an added level of anxiety and emails me, I'm going to give them a call, or I'm going to email them back and make sure that it happens that day. And not that that's necessarily new, but there's never been a more important time for everyone's staff to feel attached and supported and heard and seen. And those have really been our goals. Early on, John, maybe 10 days into it, a hospice clinician wrote an email to her team. Our hospice has essentially five branch offices, 5 teams. And one of our nurses wrote an email to her team and said, you may not feel like you're seen, but I see you and I support you. And that email got to me, and it was one of those moments we have in our careers where you have this realization that perhaps you could have been doing more. And I felt like that at the moment, that I was so focused on finding PPE and on figuring out protocols and on figuring out which assisted living facilities were open, et cetera, that maybe I didn't slow down to do the thing that I personally enjoy the most, which is to to see our staff where they are and to support them in the places where they work.
You know, Brent, it's easy to look back and know you can do a lot of things better, but it's obvious from your comments that you're communicating frequently with your team and you are leading from the front. Thank you for your leadership. Thank you. So I believe the future of healthcare is in the home. Brent, what do you see as the role home healthcare and hospice can play with this, a situation that we find ourselves in now?
Yeah. Well, John, we agree wholeheartedly with that comment. I would say that healthcare that healthcare from a national perspective is leaning more towards people's homes, because people go to, people don't recover at hospitals. They recover in their homes. They go to hospitals to be treated, including for COVID. Nearly all of our patients who have at EvergreenHealth Hospital who have been intubated and intubated for a long time, that have made it, that have gotten out and been extubated, they haven't recovered on the floors of the hospital and then gone back to daily life. They've been discharged to home, where they slowly recover, and home health is largely there to help them. In fact, our home health census, in spite of the fact that the hospital census has been decreasing, our home health census for COVID positive patients continues to increase, seeing discharges of folks going home. People, it may be generational too, but as a technologist, John, I'm sure you have, I know personally that you have great opinions on this, but people are looking for something different from healthcare now. And we feel that home health and hospice is not healthcare, it's the provision of health. It's and there's a distinction there. Healthcare is an application. Health is preventative, and it's community based. And we're so proud to be part of this, and to have companies like yours that help support folks like us that are out in the field trying to do better and be innovative.
Brett, that's very insightful the way you shared that. I would love to hear Sarah and Molly's thoughts about the role home health care and hospice can play in a situation like this.
So when you think of challenging times, and when you go through challenging times, you want to look at where you can be most nimble and where do you have resources, and that includes human resources. And you think that's home care, nimble and people ready to help. And you read more and more, and unfortunately we're seeing it, the long-term effects of isolation and how that's being tied to functional decline. And you think, insert home care. This is what we do. We can be part of this solution. It's what we do best. We have multiple clinicians, and they can reach patients quickly and support these patients, like Brent was saying, recover at home, and more importantly, stay at home and out of the hospital and the ERs. And we think of home care, we have this unique model of practice that allows for a crossover, for lack of better terms, a crossover of skills that you don't see in a lot of other care settings. So when you think about rehab and nursing, we have a rehab staff that are highly skilled but not doing as many visits here. So you think case management, where can they support these nursing cases and help carry some of that load, whether it's education or caregiver training or wound care, really trying to be creative there.
And I would say that just in general, home care clinicians have had to improvise forever. You don't have something in the home, you don't have an extra set of hands. Home care clinicians constantly make do with what is available in whatever environment they happen to walk into, whether it's a condo in downtown or a home with 3 different fences in the boonies that may or may not have electricity. It really cultivates a spirit of ingenuity and a sense of, we got this, we can do this. And you just get a greater degree of flexibility, and the home care clinicians get used to, okay, this is how we're doing it today, which really helps in a situation like this.
Amazing. Okay, so I'll switch gears a little bit and talk about staffing, which has been a challenge for our industry. So Sarah, this question is for you. Have you seen any shift in attitudes from your clinicians through this crisis?
Yes, it has been pretty illuminating to be part of an experience that happens rarely. A 100-year event, and it took some time for me personally to find a sense of equilibrium, and figure out what's the best way to move forward. And I know that I am absolutely not alone. Everyone has experienced that, including our staff. But they're operating at a different level because they are face-to-face with patients, or they're no longer face-to-face with the patients that they've developed relationships with. And staff who are normally unflappable and steady are now operating at a high-speed wobble. They're just not their normal selves. So supporting them and making sure that you provide them the information in the simplest, most clear way possible, and then repeating it, so that they get back to their equilibrium point. And I think over time, the more we learn about this virus, the more knowledge we have, that will also help to settle down some of those anxieties.
Sarah, I've got a follow-up question for you. As you're talking about staff, I want to stay on that topic for just a little longer. So what advice or guidance will you give leaders in the care at home industry for how to handle staff during this crisis? As other organizations nationwide are thinking about this and dealing with this, you have experience dealing with this. What additional advice or guidance would you share with them?
Yeah, we really leaned on our HR team to help us through those tough scenarios, because we weren't unique. In this instance, because we're attached to a hospital, there were other units, there were other managers that experiencing it. The tough questions from clinicians, so we weren't alone in that sense. So HR kind of became our clearinghouse for some of those tough scenarios, and we followed existing processes. Brent mentioned earlier the staff that their anxiety was to the point where they just didn't feel comfortable working. We walked them through a work accommodation process where they got a note from their doctor, and it's a process that we have gone through hundreds or even thousands of times before with clinicians over the last 10 years. So maintaining what you can rather than reinventing the wheel. And we had some additional latitude in the state of Washington, where, staff that went on a leave of absence, their leave was protected, and just doing our level best to maintain consistency wherever possible, and doing it across the organization. Challenging, but was very valuable whenever we were able to do it.
So Brent and Molly, do you have any thoughts you want to add to that?
I think, just really important, keeping in mind that, this is widespread impact everywhere, but really it comes down to the individual experience for people, including our staff and our leadership, and how it impacts their life in and outside of work. And that is coming into play every day, having to keep that in mind.
Yeah, John, we this is certainly unprecedented for all of us. So perhaps one of our guiding mantras has been, what are we going to be? What decisions did we make that we will be proud of when this thing is no longer here? We know. I've said it a number of times lately that home health was needed before COVID, certainly needed, and hospice and home care. Certainly needed during, and will be needed after. We need to manage our businesses, lead our businesses in a way that are going to keep us afloat. But in the same right, we have the amazing burden. I'll use the term burden as in a heavy weight and responsibility of leading our staff in a way that is going to help support them and allow them to be present with us and supporting our patients when this thing has passed. So we consistently think about that, and there is such thing as a fine line. This is a good time when thinking about HR to not think in absolutes. It's not just you lay people off, or it's not just you don't lay people off. It's somewhere in a way that's going to keep our employees fed and hopefully keep us well supported as an agency in the meantime.
Very well said, Brent. There's a lot of wisdom in your comments. So, let's talk about the regulatory landscape for a change. How has the regulatory relief provided by the federal policymakers impacted your ability to provide care at this time?
Well, I'm gonna address that question in a very politically correct way. It's helpful that federally and on a per state basis that the government is working as hard as they can to address it. It could be that the focus has been it's been so linearly focused on hospitals. In fact, this next package, number 4, is going to be very much focused on hospitals as well. Hopefully home care gets some relief in it. But we need to, our legislators and CMS in particular, need to find the balance between what is needed in the home and what is needed to continue to lower transmission. And I can't, I think both Molly and Sarah look into the quote moral imperative of what we're having to do. We have the opinion at Evergreen that it's much better for the public's good, for the health of our community, to continue to see patients that need those in-person visits, to continue to do so, because they were sick before. They needed help before. They needed help to keep out of the hospitals before COVID came. And it's even significant, it's exponentially more important now that hospitals are dealing often in an overwhelmed state with patients of only one disease type, when we are taking care of folks with thousands of disease types previous to this. And the government's ability to allow for virtual care and to clear the way for some regulatory things that need to be cleared it's super important. One example is that we know that nurse practitioners and physicians assistants now federally, nationally, are able to provide orders for home health. In the state of Washington, though, physicians assistants still can't do it. And we would think that would just be a no-brainer. It supports PAs who frankly they're having trouble finding work right now. It removes roadblocks for people to stay out of the hospital, and that's just one of many examples. So the National Home Care Association is working super hard. I know you are doing with that work, John, and we're all working with NAC and with Bill to make sure that we get some stuff, some hopefully very progressive changes pushed through as soon as possible to help us keep going.
Excellent. Brent, from your comments, I can tell that you've had a lot of conversations amongst yourself about this. Sarah and Molly have been parts of that conversation as well. So I would love to hear what Sarah and Molly think about everything you just said about the regulatory relief provided by federal policymakers. I want to hear your thoughts.
When kind of playing off of what Brent said, the two kind of big things that have the biggest immediate impact for us when it becomes to providing care or really access to care are really that expansion of the homebound status or the extension of the homebound status, and then the ARMP physician assistant certifying for home health. That's really removed a barrier that they've been working on for a long time and working hard at removing that barrier. And it's really not just during this crisis, but we're going to see that ongoing. And with these waivers and the changes from a provider level, what we've been seeing is kind of difficult to quickly implement these huge changes. Even though they're amazing, our systems are in place to prevent a lot of this from happening. And so to quickly change everything over to allow it to happen, it's been an interesting challenge. We just thought, okay, we're ready. Let's rock and roll. And we weren't quite ready to rock and roll. So we're really working hard on that piece.
Yeah, one of the things that I work on is I manage the technology aspects of everything that we do, our EMR and whatnot. And what Molly mentioned, testing it and making sure that these new changes that we put in place don't break something else down the line, is something else. It's another thing that you go, okay, check that box. We're not breaking anything down the line. And implementing telehealth, even without the ability to get paid for it, that connection piece, the ability to see our patients, their caregivers, and provide them some social contact, check in on how their chronic disease is doing and their home exercise plan and all of those things, getting that to work and doing that remotely without patients, without being in the patient home to walk them through it the first time is an additional challenge.
Got it. So, Brent, what about the financial relief through the CARES Act? Has that helped any?
So, yeah, we our system received some money, John, and that will likely, indirectly trickle down to us. But we're going to need more to make sure that it has a more tangible impact. To me, I continue to go back to more structural changes specific to home health around making sure that we are that virtual care is going to be compensated for. It seems unlikely, but I don't want to say if, there is absolutely a way for us to ensure that virtual care, that televisits, even non-video visits, just phone visits, if they're substantive and have a material value and are long enough, then they could perhaps count towards LUPA minimums. If that were the case, that would be excellent. Now, Bill Dombey and the NAC staff have been working really hard on something that's a bit simpler, and that may be just increase our payment rates by something like 10+%. And if that were to happen, and we're able to, as a provider, keep at our LUPA rates, that would be a positive thing.
Got it. And just so you know, I love all the creative thinking around this topic of virtual health, telehealth, providing additional reimbursements for care in the home. So I totally agree with everything that you've shared already. So, Brent, what are you seeing in your community now? Has the shelter-in-place strategy been working? Do you feel like you've seen a flattening of the curve in Kirkland?
Yeah, so we definitely are seeing a flattening of the curve statewide. So again, we rely on information from the University of Washington. You guys remember the name of it's the IHME. Yes. What's it stand for?
I have no idea.
The Institute for Health Metrics and Evaluation. So sorry, if you want to look up, if everyone wants to Google the Institute for Health Metrics and Evaluation, you can look up Texas, you can look up Washington, you look up any state that you're in, and it will show essentially the bell curve of deaths and infections and bed availability and PPE utilization, and it's an excellent tool, and that's what we've been using. So we have seen a flattening of the curve. Our peak was around the 5th of April. So we're on the downside, and as a state, in particular on the western side of our state, I think people are very leery to stop social distancing, in spite of the fact that we know it has significant economic impacts. But I'll be quite careful to remain apolitical in my next comment, John. But it probably couldn't be more important that people continue to look at the science of this, and it isn't as simple as just opening up a state and saying, we're going to have kids' birthday parties and reopen factories and all of the above. This thing needs to go down to effectively a minuscule level of infections per person, something like 1 in a million folks, which would mean in Washington state, we would have essentially 7 people or 8 people in our whole state that would be positive, in which case the economy could be opened back up. So there's a lot of complexities with it. I do want to mention that I think that there's been some benefit that Washington has been the quote tip of the spear, because we've been able to react in a way. It's frankly, as a provider, I think we've benefited. I would rather have just, I'd rather be at the front of the line and get through this and learn on my own versus sitting there and watching and waiting. So hopefully our advice is helpful. Yeah.
Got it. So we've got just 5 minutes left, and I'd like to hear from you, Sarah and Molly, on the key lessons you've learned in being on the front lines of this situation.
I think that I can safely say there is going to be one heck of a debrief after this calms down a little bit more, and we will have a shiny, sparkly emergency preparedness plan that is no longer based on tabletop drills and theory and best practice from everywhere else. It will be based on our experiences, what has worked, what has not worked, and lessons learned. There's a very stark difference between drilling and going through an actual disaster. Thinking about how you might respond versus learning from what you actually did.
Wow, that's profound.
I think what I've learned, this is Molly, is really, taking care of your staff and taking care of your patients, it really goes hand in hand. It's not an either or situation, and by protecting and supporting our employees, we are protecting our patients and we're protecting the community at the same time.
Wow, amazing. Brent, what have you learned?
So just in our closing last few minutes, a couple simple points. Protect your staff. Protect your staff. Protect your staff. I think everyone listening will probably assume that they're already wanting to do that, but it couldn't be more important. One that I've had to learn is this idea of being vulnerable as a leader. It means using your ears more than your vocal cords. I would say pull your team together right now. Make sure that any issues that your team has from an ethics perspective or from a care perspective, or different opinions on should you provide visits, should you not provide visits, is this enough PPE, is this not? Get your group together now and pressure test that conversation, because when it comes, it's not the right time. You got to have those things ironed out now, because in the moment you're going to need to make very quick decisions. And just know that more change is coming, and this thing is obviously, we keep hearing this is a marathon. It certainly is. I don't know what mile we're on, but
I don't think marathon is. At the recent NAC conference, I forget the climber's name, but she talked about how you climb Mount Everest and you go up and then you come back down and then you go up further and then come back down. I feel like that's the kind of journey we're on.
Melissa Arnott.
Thank you.
That's good.
Wow, yeah. Wow. This has been incredible. So we've got just 1 minute left. Any parting thoughts for others in our industry, or we have several folks in the audience that are from different industries. Just wanted to hear your accounts dealing with this firsthand. Any parting thoughts for them?
Sure. Again, the idea of protecting your staff. You got some tough decisions ahead. Remember, it's the long game. I love Sarah's reference about climbing and false summits, and this is definitely that, and I'm going to be adopting that one. This may be the moment, everyone, that public health takes a front seat in our nation. We do an excellent job in our country of honoring military folks, and they deserve it. They deserve every part of it. But the folks that are there on the front lines are, in my mind, right there with our military. And I think for Evergreen, we couldn't be more honored to be part of this response and to be part of our excellent industry. And we do also believe and agree with you, John. Home care is the future, and we appreciate the opportunity to chat with everyone today.
Thank you so much, Brent. Thank you, Brent. Thank you, Sarah. Thank you, Molly, for all your leadership in our community, in our nation, and in the world. We're so blessed to have people like you to have handled this, and then we can learn from your wisdom. Thank you for joining us today. Thank you.
Our pleasure. Thanks so much.
Oh, thank you, Brent, Sarah, and Molly. It's clear your patience and your employees are so lucky and benefiting from your leadership. And we're really grateful that you were willing to share your experience and your wisdom with us today. So to our attendees, we will provide you with a link to the recording via email, and we're really grateful that you all were able to take some time to join us in the Evergreen team today. Thank you for joining us as we continue to deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Thanks so much. Have a wonderful afternoon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.